Hello, welcome to Pathagonia. This is Jay Huang. Today we're going to talk about hepatocellular carcinoma, an overview. Before we begin, here are my references for this presentation, including path outlines, the WHO, the CAP synoptic, as well as Drs. Uthman, Torbenson, and Park for their amazing pictures. What we're going to talk about is epidemiology, imaging, etiology, macroscopic appearance, histopathology, grading, premalignant lesions, differential diagnoses, and staging. Hepatocellular carcinoma, or HCC for short, accounts for around 75 to 85% of primary liver cancers. It's the sixth most common cancer and the fourth leading cause of cancer-related deaths worldwide. Imaging is used to identify and stage hepatocellular carcinoma, and modalities include ultrasound, CT, and MRI with contrast enhancement. If we look at the arterial phase, the tumor is enhanced, whereas the normal liver is relatively hypointense. If we look at the venous phase, the tumor is relatively hypointense, whereas the normal liver is enhanced. Why is this? This is because HCC primarily receives blood from the hepatic artery, whereas normal liver receives 25% from the hepatic artery and 75% from the portal vein. More blood from the vein feeds the normal liver, whereas the hepatic artery feeds the cancer. So I am not a radiologist, so you may have to correct me if I'm wrong, but what I believe we're seeing is this portal venous phase, and whereas the normal parenchyma is hyperenhanced, or is enhanced, the tumor is relatively hypointense here. Etiology, approximately 90% is related to a cause, including chronic liver disease. In terms of microbiology, Hep B, Hep C, steatohepatitis, that can be due to alcohol intake or non-alcoholic, such as metabolic syndrome. Genetics, including hemochromatosis, alpha-1 antitrypsin deficiency, glycogen storage disease. Exogenous exposures like aflatoxin B1, and rarely it may arise from a hepatic adenoma. Of note, fibrolamellar HCC subtype occurs only in non-cirrhotic livers, generally in young individuals, like 20s. Here is an H&E of fibrolamellar hepatocellular carcinoma. We see eosinophilic tumor cells with ample cytoplasm. There's some fibrosis as well. We see trabeculated architecture with a background of dense collagen bundles. The cells are large, and there's prominent macronucleoli. Macroscopic appearance, it can be green to yellow to tan depending on the fat and bile content of the tumor. It often has a pseudocapsule, which is inflamed, and fibrotic tissue microscopically. And there are four main macroscopic patterns, including single nodule, large nodule with smaller satellite nodules, small nodules that can number from the dozens to hundreds, and multiple distinct nodules that are independent primaries. So here is an early HCC in a cirrhotic liver. In the arterial phase on a CT, this would be enhanced, and then in a venous phase, this would be hypointense. And then you can see another HCC in a cirrhotic liver as well. This is a HCC in a patient with hepatitis C. Unfortunately, this got cut off. Histopathology, you'll see loss of portal tracts. You'll see reduction or loss of the reticulum framework. You'll have increased arterialization, including aberrant arterioles and sinusoidal capillarization, as highlighted if you do a CD34. And this helps explain why their arterial enhancement will increase intensity of the tumor. Cytologic atypia can be minimal to marked depending on how differentiated it is, well, moderately or poorly differentiated. And there's four histologic growth patterns in HCC, and approximately 50% of cases have mixed patterns of these four. These four include macrotrabecular, meaning the trabeculi are greater than or equal to 10 cells thick. There's pseudoglandular, pseudoacinar, trabecular, and solid. So here's a case where we can see aberrant arterioles. We don't see any portal tracts. We have the pseudoacinar structure. And in cytology, you might see in this correlate endothelial wrapping. Here is an instance of pseudoglandular or pseudoacinar architectural pattern. Here is a trabeculated pattern in the same biopsy specimen. And here's a reticulin stain showing the loss of the reticulin meshwork. This is a macrotrabecular growth pattern, and as you can see, there are more than 10 cells making up a trabeculae. Cytopathology, findings suggesting hepatocytic differentiation as opposed to metastasis, is abundant eosinophilic granular cytoplasm, some fatty change, bile production. Findings suggesting malignant hepatic lesions include high cellularity, high LN bodies, high nuclear to cytoplasmic ratio, nuclear pleomorphism, multinucleated cells, naked nuclei, mitotic figures, and architectural changes suggesting malignant hepatic lesions, including pseudoacinar change, thick trabeculae, and endothelial wrapping. So in this hepatocellular carcinoma FNA, you can see a thickened trabeculae and maybe a suggestion of transgressing vessel. Here you can better appreciate the thickened trabeculae, and here you may appreciate some suggestions of endothelial wrapping here. There are subtypes, and approximately 35% of HCCs can be further subclassified into these subtypes, including steatohepatitic, approximately 5 to 20% relative frequency, has a similar prognosis to just a HCC without a subtype. Clear cell, 3 to 7%, it has a better prognosis. Macrotrabecular massive, 5% relative frequency, has a worse prognosis. Serous, 4% relative frequency and has variable prognosis. Chromophobe, looks like your chromophobe carcinoma in the kidney, and it's 3% relative frequency and it has similar prognosis. Fibrolamellar, it has 1% relative frequency. It's in a non-cirrhotic liver in a relatively younger patient. It's similar to HCC that develops in a non-cirrhotic liver. Neutrophil rich, it's less than 1% relative frequency and has worse prognosis. And lymphocyte rich, it's less than 1% relative frequency with better prognosis. So here's a steatohepatitic variant of HCC, where it looks like you have steatohepatitis. This is a clear cell subtype of HCC. It's clear because of the glycogen content. Chromophobe subtype, where the nuclei kind of look plant-like or coilocytic. Lymphocyte-rich subtype, where the lymphocytes outnumber the neoplastic cells. Serous subtype of HCC, where you have abundant fibrostroma, where more than 50% of the tumor is made up of fibrostroma. Immunohistochemistry. Arginase 1 has cytoplasmic or nuclear staining, and it's useful in confirming hepatocellular differentiation as opposed to metastasis. HepAR1, it's cytoplasmic and granular. It can stain normal hepatocytes as well as well-differentiated HCC. However, 50% of poorly differentiated HCC lose expression. Given that, you want to order a glypican 3 too. It stains cytoplasmic and it has high sensitivity in poorly differentiated HCC. However, but low sensitivity in well-differentiated HCC, and that's where your HepAR1 comes into play. CAM 5.2 cytokeratin is positive, although AE1, AE3, and MOC31 are negative. CK7 and CK20 are negative, and that's part of your CK7-20 differential, including prostate cancer, which is also CK7 and CK20 negative. Grading is based on degree of differentiation on H&E compared to your mature benign hepatocyte. So well-differentiated, it resembles your mature hepatocytes. The cytoplasm, it'll be abundant eosinophilic to moderate and basophilic, and nuclei has minimal to mild nuclear atypia. Moderately differentiated, it'll be clearly malignant on H&E, and morphology strongly suggests hepatocellular differentiation. Cytoplasm, you'll have abundant and eosinophilic to moderate and basophilic. Nuclei will have moderate nuclear atypia, and occasional multinucleated cells are okay. Poorly differentiated, it'll be clearly malignant on H&E, but morphology is consistent with a broad spectrum of poorly differentiated carcinoma. The cytoplasm will be moderate to scant, usually basophilic, and nuclei you'll have marked nuclear pleomorphism and may include anaplastic giant cells. So here's an instance of well-differentiated HCC, where you're not sure if it's cancer or maybe a hepatic adenoma. This is moderately differentiated HCC, where you have more cellular atypia with anisonucleosis, and poorly differentiated HCC, where it doesn't look like a normal hepatocyte, and you wonder if this is actually a metastatic lesion. Premalignant lesions, it's found almost exclusively in cirrhotic livers, and it includes dysplastic foci. These are microscopic lesions less than 1 millimeter in diameter, and it's incidentally discovered. Hepatocytes with cytologic alterations include small cell change and iron-free change. This arises in the setting of iron storage disease. And dysplastic nodule is seen on imaging or macroscopically, and it's usually 5 to 15 millimeters. The prevalence is around 11 to 40% in cirrhotic livers, and it's classified as low or high grade. High grade will have small cell change, plus or minus pseudoglandular change. It will have a clonal appearance, and it'll have 1.3 to 2 times increased cellular density surrounding the liver parenchyma. And differentiating low-grade dysplastic nodule and large regenerative nodule may be difficult with no widely accepted histologic criteria as of now. This is an instance of small cell change where you can see the change in the middle compared to your surrounding hepatocytes of larger size. This is low-grade dysplastic nodule with patchy large cell change. This is high-grade dysplastic nodule where small cell change can be seen. Your differential diagnosis for HCC include intrahepatic cholangiocarcinoma, combined hepatocellular cholangiocarcinoma, where it's important to determine this because treatment is based on the cholangiocarcinoma portion. Metastasis includes neuroendocrine tumor, urothelial carcinoma, non-keratinizing squamous cell carcinoma, amelanotic melanoma, and well-differentiated HCC may be difficult to distinguish from a dysplastic nodule, hepatocellular adenoma, focal nodular hyperplasia, and regenerative nodule. Thank you for watching. If you like this video, please give a like and/or subscribe. And if you are already subscribed, thank you so much for your support. We'll see you next time on the episode of Pathagonia.